All right, let's review the botulinum toxin injections for chronic migraine therapy. Again, I will dedicate the talk to the memory of my father, who passed away in 2016, and he really encouraged me to do more education and teaching, and I do all in his memory. So, at the end of this talk, what we would want to achieve would be you should be able to explain the diagnosis and selection of proper candidates for botulinum toxin therapy with chronic migraine headaches. You should be able to describe the standard injection paradigm recommended for botulinum toxin therapy and then explain basic injection techniques for the therapy for chronic migraine. Let's start again with a case. Let's say that you're seeing a patient, Sarah, and Sarah is an active mom. She has two kids who has been suffering from her headaches for more than a decade, and she says that migraine runs in her family or headache runs in her family. She had learned to ignore it for most parts, but recent stresses of husband changing jobs, use of contraceptives, and moving to new house had been too much. In last 6 months, she has tried everything from the Tylenol, paracetamol, aspirin, ibuprofen, caffeine, and herbal meds, everything over the counter. She reports having some headaches nearly 21 days a month, and more than half of those headaches are lasting more than 4 hours, and they're associated with nausea and photophobia. She is at her wits' end and has been five other doctors the last 6 months with no relief. Has tried many of the prescription medications, and she would think that discussing Botox therapy would be useful with her. The question is that, with this context, with this clinical background, what you're trying to decide is that what is she a good candidate for Botox or not? What would you tell her about the benefits of Botox injections, and what would she do, or what would happen if the injections don't work, or what's the likelihood of they're not gonna work? So as we go through the rest of the presentation, I want you to focus on these questions so that you can translate the practice to your own patients. The Botox for migraine, it was a serendipitous discovery for the treatment of migraine. Dr. William Bender in 92 in LA, he was injecting the Botox on a botulinum toxin A into patients' foreheads for treating wrinkles. And several months later, many of his patients reported a lessening of migraine symptoms, and that was the first correlation between the use of toxin and reduction in headache severity. Since then, there were many studies done. Many headache experts started using Botox as part of their treatment protocol for patients with headaches. Studies, for the most part, failed to confirm the effectiveness of episodic migraine or acute migraine. There was only one study that was positive, and that had one uninterruptible dose response curve. And doctors and patients kept on reporting positive results, but the studies were not being positive; they were failing until we had the final study. The final study was based on chronic migraine. Chronic migraine affects 2% of population and is defined as having 15 or more headache days per month, or more 8 headaches of migraine per month, and lasting more than 3 months, or actually more than 6 months. But when we select Botox for chronic migraine therapy, we want to see at least 15 headache days of a burden per month for the last 3 months. Headaches less than this may respond, but the chance of benefit goes down. We know that the chance of benefit is very high when someone is having at least 15 days of headaches in a month. When I say a day of a headache, what I mean is that a, a day which had some headache, it doesn't have to be that the whole day had headache. It could be few hours. Half of those headache days has to be migrainous, meaning that there was migraine characteristics. So again, 8 headache days per month were migraine, so at least half of the 15 headache days per month. And migraine headaches, meaning that the headaches without treatment are lasting 4 hours or longer, and they have nausea or photophobia associated with them. So the pivotal studies were preempt studies, preempt 1 and 2. There were two back-to-back studies involving the same patient population, and these preempt stood for phase 3 research evaluating migraine prophylaxis therapy, and it was using botulinum toxin A, and it showed that the therapy is safe, well tolerated, and effective, which was the key message here, which was not seen in the earlier trials. We're not sure exactly how botulinum toxin really works in blocking the headaches. What we think is that it inhibits the release of nociceptive mediators such as glutamate, substance P, and calcitonin gene-related peptide from peripheral termini of primary afferents for nociceptive pain within the skin or in the subcutaneous tissue. In the preempt study, both 1 and 2, it was a 24-week double-blind study, actually 32 weeks with follow-ups included. So the injections were 12 weeks apart or 3 months apart. So you had enrollment at baseline, then you had the first session, then 12 weeks later the second session, and then 12 weeks later you have the culmination of the study. 32 weeks of open label extension was done afterwards, so those patients continued to stay on therapy. Remember, it was a double blind placebo controlled trial initially, so half of the patients were not getting Botox, were just normal saline shots. So the patients decided to continue to just go on open label, meaning that everybody started getting Botox after the 24 weeks for another 2 sessions or so. There were more than 1,382 patients encounters that were done. So I think it was 600 something patients. That was 650 or something. So there was 2 sessions with each patient. For each session, for the first session, 155 units of botulinum toxin injection, botulinum toxin or Botox, was given in 31 sites. And on the follow-up session, on the second injection 12 weeks later, additional up to 40 units were allowed to be given above 155. So 155 was minimum, nothing below was allowed. And it has to be given in 31 sites, as 5 units each on each site. After that, on second session, you could add additional units if you wanted to. So very well designed protocol for therapy. And this is still what we follow in practical use case of Botox for migraine. So in this trial, we look for the primary outcome or improvement in headaches after 2 sessions. So after 24 weeks, there was some improvement after first session, but that was not the primary target. We were looking at improvement only after 2 sessions of Botox. So that's what I tell my patients, that if we're going to go for Botox, then we should do 2 sessions at least before figuring out if it's working or helping or not. And then the improvement they saw on average was 8.4 days of headache reduction. So based on headache diaries that the patients were keeping on a daily basis, and there was about 5.2 less headache episode. An episode can last longer than a day. That's why the number of headache days was 8.4 days of reduction, which is what we basically tell patient that your headaches days. So in the trial, that this was about 50% improvement or 40 to 50% improvement in the number of headache days, and that's what we'd recommend to the patient. We don't promise headache freedom, but in the trial, 20% of the patients became headache free, so 1 in 5. So I do say that there's a 1 in 5 chance that your headache may go away completely, but 80% of patients still had some headache, but their days of headaches were less. When the trial was designed, it was designed with a very specific protocol. There were 31 sites of injections that were decided. There was 1 in the midline and then 15 on each side. And there were fixed sites that we will review in the presentation later on. And everybody was supposed to use the exact same sites on the first session and at least use them in the second session. Plus, you can do some more. So in each of these sites, there was fixed amount of dose of Botox given. It was 5 units on each of these sites. The study used 2 ml dilution or 2 ml for 100 units. So each 5 unit was 0.1 ml. So 0.1 ml or 5 unit given on each of these sites was the study protocol. We still follow this protocol mostly based on the findings from the clinical trial. There are some side effects that happen. The most common side effect that I have seen and was seen in the study was that almost a third of the patient after the first session especially, they had an attack of migraine that started because of the poking of all these tender sites. There was tenderness and pain on injection sites, and some patients in the study, I believe it was 12 to 15% were getting head drop. The head was becoming heavy because of the injection back here were deep. That is not a big problem anymore because we don't use EMG needles to give injections, and we don't give them intramuscular anymore, and we also give them a subcutaneous injection. Similarly, eyelid droop was very common, I believe 15 to 17% in the study. That is not very common anymore just because of how careful we are with our injection. And similarly, double vision was seen in 5 to 10% of patients, but again, I don't see that in my practice anymore. Migraine is still an issue. Tenderness, pain is an issue. It's unavoidable. When you have first sessions and these are tender sites where you're injecting, then you are bound to cause some headache in about a third of patients or so. And I tell them about it, tell them just treat it routinely, and that usually is enough. So I use a 30 or 31 gauge needle. So it's a very, very tiny needle. The thicker you use, the more painful it will be, more tender the sites will be. It's usually a 1/2 inch needle, and I don't need to go deep in. I don't want to go into the muscle. Head drops happen if you go too deep into the muscle. I use the one with the slip lure lock, meaning that it's easy to change the syringes, because if you use 50 unit preparation and you're using 200 units, that means you have four 1 ml syringes. Each zero point 0.1 ml is 5 unit. So that's very easy. We call it a tick in practice. I'll show you during the workshop. And we just basically give one tick on each site as the initial protocol. And then, of course, you can add later on the follow-up injections. You need to insert the needle with bevel up 45 degrees, and you have to go subdermal, not intradermal. Again, these things I can show you in the workshop what that mean. And you want to make sure that the drug is not given intradermally. It is subdermal that is given. It doesn't form any blanching of the skin. Things I can show you during the workshop. Let's talk about the sites of injection. I divided the injection sites into three main groups. So there's a frontal group, then there's a lateral or temporal group, and then there's a posterior or occipital or cervical group. So the frontal group is basically these injections. As I mentioned, there is one in the center, which is right between the two medial end of the eyebrows, and this is called the procerus injection because of the procerus muscle there. Again, these are named after muscles, but they are not intramuscular injections per se, although it's hard to avoid subcutaneous muscles. So when you give subcutaneous injection, because procerus is there, it is expected some drug will go into it. The only way to know would, because procerus don't have much of a function, but the only way you would know is that if they have, a crease there on the forehead because of the procerus involvement, the crease may disappear. The next two are after that 15 on each side, so they're all matched now. So one on each side will be the corrugator, so that will be the medial eyebrow injection, and then two will be the frontalis, and there will be high up injections on the frontalis muscle. And again, I will show them here what they look like, but I would also explain to them during the workshop. So this is a procerus injections. It's right in the midline. You basically take the medial end of the eyebrows, you draw a line between them, and you go right in the center. And sometimes you insert a little below it, because once you insert the needle, you're very slanting, so there is some travel under the skin, and the tip of the needle will be much higher from where you injected. There will be some moving of the needle upward or to one direction. Sometimes I lift up the skin when I'm picking if I'm not sure if I'm gonna be able to go under the skin easily, or you can stabilize the skin. Again, these things I can show you during the workshop. Corrugator is these sites here. These actually are not corrugator injections. Corrugator is the deepest muscle here. There are 3 layers of muscle here. We will look into during our cadaver dissection. We'll try to see if we can identify it. And corrugator is the deepest muscle. So it used to be, even in a clinical trial, you would go straight deep in to do the injections, but not anymore. We just do it under the skin, subcutaneous, although the name is corrugator. It doesn't have to be into the corrugator muscle. If you do inject corrugator muscle, it can sometimes cause drooping of the medial end of the eyebrow, and something that has been called like a Spock sign or inverse V sign. The mid get lifted up and the medial end drops, and that causes like a V shape of the eyebrow, and very prominent and noticeable. It does go away. Frontalis muscles are 2 injections. The way you identify the frontalis is that you look at the pupil. You take the midpoint of the pupil and go straight up from the mid-pupillary line, and then you are 1 finger breadth below the hairline, where the hairline should be, not receded hairline like mine. But let's say my hairline is supposed to be here, then a finger breadth below here will be somewhere here will be the first injection, in line with the midpoint of the pupil. And then the second one will be 1 finger breadth away from it. So you give the first one, you can put a finger just to get your finger breadth if you want to, but gradually you will start understanding what is a finger breadth, and then you give the second one lateral to it, a finger breadth lateral. I point them away from the midline to avoid the levator palpebrae superioris weakness and ptosis that was being seen in the clinical trial with migraine. This is the second one.
Very good.
And this is a video that is showing those injections. So here's the procerus one. I did lift up the skin to go underneath, and you can see I'm lifting the skin up a little bit and giving that bump. There should be some spread of that drug that you're giving, 0.1 ml, but it should not cause blanching of the skin and should not remain localized. That means you're intradermal. This is now the corrugator one. This is my old technique, so I am lifting it up and I'm going straight in. I don't follow this technique anymore. These injections were from, I believe, 2016, but you kind of see the location of the injections. The location is okay, but I would have done it more slanting, recently. And now you see the frontalis. I'm going the mid-pupillary line straight up, a finger breadth below her hairline, directing it laterally, more outward, under the skin, and then again 1 tech or zero point 0.1 ml there, and then 1 finger breadth lateral to it. I didn't measure with the finger breadth just because of the practice. You don't have to do it. And that's how you can kind of see the sites of my needle insertions. All right, the lateral group is easy. There's only 4 sites in one muscle. It's temporalis muscle. It's a big muscle. You have to give 4 injection. There is a way to localize this 4 spots. I am not sure if you have to exactly follow it, but in let me show you on this side. So typically you take the tragus and you draw a straight line up, imaginary line, not with a pen. You go up and basically you go up 2 finger breadth higher than the upper end of the tragus, and then here you give the first one, and then you go 2 finger breadth higher in the same line and you give the second one. So you get the 2 shots here, and then you go in between the 2 and 1 finger breadth. I'm trying to adjust the camera. 1 finger breadth in between the 2 and 1 finger breadth anterior to this. So in between will be here, and 1 finger breadth will be here. So this will form like a triangle. So you'll have the 2 first one and the third one a little bit anterior, and then the fourth one will be behind the top one. So the top one that you give, you go 2 finger breadth posterior to it, and that's where you give the fourth one, which is almost in the middle or apex of the pinna of the ear of the patient. So these are the 4 shots that you give. So these are the temporal shots, the first, the anterior one, and then the posterior one, I believe. No, this was the posterior one. And here is a video showing those shots. I'm showing you the line in 2 finger breadths higher. Here's the first poke. It's under the skin. Temporalis is very thin. It's very likely you will end up in temporalis muscle. So that's okay. There is nothing against not giving it into the muscle in the temporalis muscle. 2 finger breadths higher than that was the other one in the same line. 2 finger breadths behind the top one is the third one.
Let's put it back.
And then the fourth one will be between the first 2 that I gave, about a finger breadth anterior to it. This is my old technique. I used to do it 2 finger breadths anterior, but then the newer technique is 1 finger breadth anterior. All right, the back one. So you have 8 injections on each side on the back. So a lot of injections, or 3 groups. So you have the occipital group up in the occipital area, 3 of them. Then you have 2 in the paracervical, just below the bottom of the skull, so start of the neck, still within hairline. And then you have the 3 down the shoulder. So occipitalis, the way you identify occipitalis is, I'll show you during workshop again. It will be, you take the mastoid bone and then you feel the occipital protuberance and you draw an imaginary line. And occipitalis first injection is a third of the way from the mastoid on this line, or 2/3 from the occipital protuberance. And then the next 2 you give above the first one, and those 2 are given, one a lateral to the first injection, and second one above and medial. So above and lateral, above and medial, to make almost like a V. So you give the first one, and then you give 1 finger breadth lateral and medial and above, and one finger breadth lateral and above. So this is the second, and this is the third injection. And then paraspinal. Paraspinal, you feel the lower edge of the skull, and just below the lower edge of the skull, you go 2 finger breadths below in the midline, and then you give it 1 finger breadth or half a finger breadth lateral to the midline. And that is still within hairline for most people. And then the second injection, you give 1 finger breadth higher than the first one and also lateral. So almost like one side of the V. So you give the first one 2 finger breadths below, half finger breadth lateral to the midline, and then you give the second one 1 finger breadth higher and lateral to the first one. So this is the first one, and this is the second one. Trapezius. So trapezius, you look at the end of the straight part of the neck where the curve starts. So you take that point, and then you feel the shoulder, the acromioclavicular joint, and you feel that point. And you take the midpoint between the 2 as your point for trapezius, and you go 1 finger breadth behind the anterior edge of the trapezius. So whatever edge you feel for trapezius, you go a finger breadth behind, halfway between the end of the straight edge of the neck and then the acromioclavicular joint. That's the first one, and then the other two you do lateral and medial to it. So one you do two finger breadths medial to it, and one you do two finger breadth lateral to it. Again, I will review these sites during the workshop. So this one is two finger breadth medial, a finger breadth behind the anterior edge of the trapezius. And this one is two finger breadth lateral. This one, you don't want to go too lateral. If you're too close to a acromioclavicular joint, you can cause some shoulder drop. So I try to do it sometimes only a finger breadth lateral to the midpoint if there is a narrow shoulder in a patient. All right, I believe this is a video showing you the injections for occipital. So I'm feeling the occipital protuberance, and then I'm feeling the mastoid. I'm drawing an imaginary line between the two. I'm going to take 1/3, 2/3 junction and give the first poke there under the skin. So 1 tick or 0.1 ml over there, and then I'm going to go 1 finger breadth superior and medial to it.
1 finger breadth above and lateral.
And then 1 finger breadth superior and lateral to it. So forming a V.
And paraspinal, lower end of the occiput.
And then I'm going to feel, and you can see I'm doing it without EMG guidance and still the half-inch needle. I don't want to go too deep to do intramuscular injection. So I'm going 2 finger breadth below the lower edge of the skull and 1 finger breadth lateral to the midline.
1 finger breadth up and lateral.
And then 1 finger breadth lateral and superior to the first one.
Very good. And then trapezius injections. Acromioclavicular joint. Angle of the neck.
Middle. And the end of the straight edge of the neck.
The bar of trapezius.
Midpoint to that. This one you can go straight in. Half an inch is not a lot, but even if you give into the muscle, that's probably okay. Unless you're too lateral and you can cause shoulder drop.
And 2 finger breadth lateral. Very good.
This may be a little too lateral on this patient, but in general, I try to stay a little more medial than that. All right, so I've reviewed dilutions before. The standard dilution is 2 ml dilution. So for 100 unit vial, you want to put 2 ml, or for a 200 unit vial, you want to put 4 ml, and that will be considered a 2 cc dilution. The number of cc is per 100. So 2 ml dilution or 2 cc dilution means 2 ml per 100 unit of vial, 100 unit toxin. And so you get 0.1 ml per 5 units of the vial. You need 155 for the first one and up to 195 for the second one. Thank you. See you guys soon.